So I want to really build on what John said and what Patricia said. I don't want to duplicate, I don't want to go over, I think all really valuable contributions, but tell you a little bit about our story and what we're trying to do. So you will see in front of you the patch that I cover. I'm one of the system leaders for the Barking, Havering and Redbridge Health and Social Care Economy. Collectively, the 8 local health and social care organisations have come together with a common challenge to create a sustainability plan, get that right, for the local system. So just a little bit about our system, and our system isn't necessarily special. You'll all come from a system from organisations that are similar. So we cover about 750,000 people, 3 local authorities, 3 CCGs, a big integrated community and mental health provider combined with a large acute trust. And no doubt there are people here who know more about the detail than me of those organisations. Along with that, we have 133 GP practices, 142 pharmacists, a number of private sector organisations, a number of third sector organisations, a number of voluntary sector organisations, I think probably about 450 organisations that work in that patch who deal with our local community. So you can imagine the complexity of contracts, commissioning arrangements, provider arrangements, dealing with people around places and around individuals. At any one point in time, anybody with a long-term condition may have 10 to 15 organisations working with them. So that in itself, how do you integrate care? How do you deliver seamless care that delivers better outcomes for people around individualised packages? Something needs to change, and it needs to change radically. So we've taken a kind of approach of saying, what are our challenges in the context of the 5-year forward view? In the context of today, what are the gaps and how do we close them? So on one sheet of paper, we tried to articulate what are the top things. And this, without going into detail, you're free to have a look at this. It's on our website and we're tweeting about it at the moment. These are our common challenges together across all of those organisations. This is our deprivation where we have one of the 3rd most deprived boroughs in the country, but equally we have areas of affluence too. So how do we deal with those challenges when our mortality rates are relatively high in one borough, but actually people are living a well and thriving life in other parts of other boroughs? Our population is going to increase dramatically in the next 10 years by 15%, both in terms of 22% for children and 20% for older people. So it sets up a real dynamic in terms of how we're going to deal with that growth in the context of the financial challenge you've already heard about this morning. We have a number of health and wellbeing challenges around obesity, alcohol use, and other types of things. And clearly, we have a number of quality challenges. We have a trust that's currently in special measures, although hopefully likely to come out very quickly. We have 1 in 2 people over the age of 75 has a long-term condition. Going forward, we have some fixed financial challenges. We have a PFI arrangement, which, as you all know, is a limiting factor. And we've already heard about the public health and the local authority cuts, which are happening as we speak, as local authorities are setting their budgets this week and next week. And if we do nothing about that, we're going to end up with a £400 million gap in the local system within 5 years. So that's the reality of what we face in the context of 450 organisations. So how do we solve that challenge is what we need to think about collectively at all levels of the system and engaging everybody within it to think about how we do that. So change is inevitable. The question is, how do we organise it in a way that delivers better outcomes and care? So this is starting to be our approach. It's under discussion at the moment and it's kind of emerging. So we're trying to say, imagine not having all of those different organisations. Let's start with the 8, because they're the biggest and the most powerful, the statutory health and social care organisations. And let's say if we delivered care in a different way through different care models, focused on prevention and thinking about earlier intervention, focused on urgent and emergency care. We happen to be a vanguard for urgent emergency care, so that's helpful. So we get a little bit of non-recurrent funding and a little bit of attention. How do we focus on people with mental health needs, planned care, And how do we transform and think about primary care in all of its contexts around GPs and also pharmacists too, and think about that as the fundamental building block on which we deliver different services. This is going to be the approach. I don't know why the 5 hasn't come out there, but anyway, it should say times 12/15. This is going to be our approach, which kind of John's trailed a little bit in terms of Redbridge. They've got 4 localities. Well, what if we had 12 to 15 localities across the system, place-based organisations that are built on a foundation of primary care representing 50 to 70,000 people who self-organise the delivery of care focused on individuals, supported by effective informatics, delivered and provided by integrated community mental health and acute services. What if those organisations were encouraged to develop, thrive, and think about the skill mix that they would need in order to deliver better outcomes from people, given the constraints that we've got, supported by our transformation programmes across the system. So try and imagine a world where we didn't have all of these organisational self-interests, and put yourself in the place of a local user and think about how things could be different and how could we do that. Before Christmas, we went to the Treasury and we said we want to be a sub-regional pilot for devolution and for developing an accountable care organisation. So we're in the process now of developing a business case that aligns to that vision, to say, actually, we need to move faster, we need to deliver better, we need to think about a completely radical solution to this whole challenge that we've got, because there is nowhere else to go in both the short and the medium term. Now, I don't know whether that business case will be accepted by all of our local partners and if it will deliver on everything I've just said. We're working through the possibility of that happening. But I kind of think we're all being given permission to take risk, as John said, and to do things differently at pace. That will create tensions, but if we don't, I think it's going to create more disruption and risk and tensions for the people that we serve. There are new models emerging internationally, globally, everywhere across the country. So people will know about some of these. You know, ChenMed in the States, which is an accountable care organisation delivering for people with long-term conditions. We've created a similar organisation in Redbridge called Health 1000, which I mentioned when I came here last year. That's now thriving too. That just focuses on managing people around their 5 long-term conditions. There's dedicated GP practice with a capitated budget and a whole integrated workforce around health and social care. Birdsong, people have known about in terms of the Netherlands, and the integrated community services are place-based and self-organised to deliver effective outcomes. And Northumbria yesterday launched their model in terms of what they want to do as an emerging accountable care organisation and how that needs to move at pace. There are other models in Manchester, in Yeovil and other types of places. We're all thinking about this. And the little diagram, which also mentions Redbridge, is something that John and I, we've been working together now for 12 years. And we produced our Redbridge Rich Picture 8 years ago. We're now starting to implement that because we've built the relationships, the trust and the values between ourselves as system leaders to be able to say we can do it, we can put our own self-interest and organisational interest to one side and think about doing things differently. So you'll know this better than me. My final 2 slides are about what's the impact. So we have to think about everybody having the right competency to focus on prevention and early intervention, not just treatment and illness. Everybody, including me and you, needs to be sending out a message about intervening earlier and adopting a different lifestyle to think about how we model that going forward. I've mentioned it multiple times in the last few minutes about organisational self-interest and the need for place-based teams, and that's intentional because I think that's the bit that gets in the way. Partly because of the regulation that we have nationally and multiple regulators driving us to compete, and clearly that needs changing at the same time, and that will be part of our business case to adopt a new regulatory model locally about how that can happen and not be a barrier. Clearly, we need new roles, mostly thinking about capabilities in primary and community services, if we are all agreed that early intervention and prevention has to be our primary objective. That will mean people need agility and need resilience personally to be able to change the way they currently operate. That's going to happen. How do we equip people with those skills in the near to short term to be able to say change is going to happen, it's going to happen fast. It's not going to be top down, it's going to be local, and it's going to be driven, or you're going to be driven by it. How do we create new career opportunities? A bit like John was saying around his social workers. This is exciting if you make it exciting. It's bloody scary if it isn't. And we need leadership, not because leaders are special, but people need to follow. So we need people at all levels to step forward and say, this has to be the way that we move together. In terms of OD type stuff, well, you know, this is your bread and butter, I guess, for many people in the room. Workforce modelling and planning, fundamental. You know, haven't been good at that. We need to get much better at that in terms of not just 5 years or 10 years, but next year. What do we need by way of competency, skill, and role? Aligning the commissioning of education and services. Well, since I've been alive, we've been talking about that, and we need to see how we can do that in reality. I suppose moving on to hearts, minds, and behaviours, in some ways that's the most pressing, so I can talk about this. But, you know, when I go back, we still have these really difficult meetings between chief execs, working through the detail about where does the deficit sit? Does it sit with you or me? Because one of us is going to get kicked for that deficit, and so we need to work together to support each other if we make those difficult decisions. And that applies, you know, in different scopes, every level of the organisation. Behaviours is ultimately where we need to head in terms of team working between clinicians and managers, between clinicians and managers and people and patients. And communication. So, you know, fundamentally, how do we get people to come with us? And that's inevitably the biggest challenge of them all. So, thank you all very much. Hopefully I haven't gone over time, and look forward to some challenging questions.